following is a voiceover of some basic nutrition concepts for infant children and adolescents. By going over these slides now, it will generate a lot of extra time in class for us to be able to do some case studies, some Kahoot testing, and otherwise activities that will enable us to learn to apply the information that we are learning. This quick review includes things that many of you may have had already in your nutrition class. So again, it is a brief reassessment and re-giving of the information. Basically, nutrition, as we know, is the intake of foods and nutrients and how our bodies convert those things for our metabolic use. There are two types of nutrients, both macronutrients and micronutrients. When we look at macronutrients, the definition of those is that they are the major building blocks for our bodies. There are three major types of macronutrients, and they fall into the categories of carbohydrates, proteins, and fats. So let's take a look at carbohydrates, something we all probably love more than anything else in our diets. The main function for carbohydrates is as an energy source. And generally, that should make up approximately 50% of the calories that we take in any given day. Our liver plays a significant role in converting carbohydrates to the glucose that we use. There are numerous deficiency disorders that will result if a patient or a client does not take in the correct number of carbohydrates per day. Eventually, the body will give out and begin to show signs and symptoms of compromise. Proteins is the second form of macronutrients. And proteins in general are made up of amino acids. In your nutrition class, you probably learned all about those essential and non-essential amino acids. You do not need to know any of the specifics of those for the exam. However, just know that metabolism is the breaking down of proteins and anabolism is the resynthesizing of those proteins. And what I want you to remember is that there are deficiency disorders, which we will be addressing, that are the result of a decrease or a lack of proteins in the diet. Many of the deficiencies that we will see will occur for proteins will occur in either areas that are significant poverty or in areas such as third world countries where protein availability is quite limited. Finally, the last macronutrient is fats. The role of fats in our body, as we all recall, is for an energy source, but we also use fats for cellular processes such as clotting. There are saturated and unsaturated fats. You do not need to be able to separate those for any exams here, but please do recall those from your nutrition class as we do anticipatory teaching and guidance with our families regarding proper diets. With regards to micronutrients, these include vitamins and minerals, and in particular include water-soluble vitamins and fat-soluble vitamins. When we look at the standards of intakes, many of us know of the recommended daily allowance that we often see on packages that we buy at the grocery store, on the back of cereal boxes, milk cartons, etc. The dietary reference intake is actually an intake reference that was developed by the Food and Nutrition Board for the Institutes of Medicine. So it is slightly different and will include estimated average requirements. Those estimated average requirements are about 50% of the population and what they may need. The recommended dietary allowance, which is what many of us are used to on those cereal boxes, is an estimate of the needs for approximately 97 to 98% of the population. So there is a difference in terms of the estimated average requirements, or what approximately 50% of our population needs, and a recommended dietary allowance, or what approximately 98% of our population needs. The most important thing that we use in the world of pediatrics and many other worlds of nursing is the MyPlate concept. When we're looking at dietary intake standards and teaching our patients and families about the appropriate intake of micro and macronutrients, the easiest guideline to give patients and their families is the MyPlate Food Guideline, which all of you have been exposed to probably several times through your school nursing school training so far. Remember that this focuses on categories of foods, and it's easy for even young children as well as adults to take a look at that plate and understand the categories of foods that we may need. One thing to remember is that while the categories remain the same, the amounts of those categories change over time. And when we discuss the dietary intake and specifics for each age group, infants, toddlers, preschoolers, school age, and adolescents, we will be discussing the specific amounts and how we measure those so that we learn to do the proper intake and such can treat or teach our patients' families about their proper amounts for intake. One other last item I did want to touch on in this voiceover was breast milk and infant formula. You will learn a lot about breast milk, how breast milk is produced, and the amounts of breast milk produced by mom when her milk comes in after delivery when you go through the second half of this course in maternal and OB. Here, though, we will be discussing infants who have intake of either breast milk or infant formula and the differences in terms of supplementing them, as well as following and tracking growth and development with them. So I want to touch briefly on the makeup of breast milk. In particular, there are obviously carbohydrates, proteins, and fats in breast milk. Breast milk's carbohydrates are primarily made up of lactose, and lactose is something that provides energy, but also enhances the ability to absorb calcium, magnesium, and zinc. The fat content in breast milk. About 98% of breast milk fats are triglycerides. There may be a small amount that is cholesterol, and research has now shown that breastfed babies, because of that small amount of cholesterol, actually do tend to have later in life much more decreased harmful effects of cholesterol in the long term for those infants that were breastfed. So infants require about 50% of their calories from fat. Those fats help them absorb those micronutrients of vitamin A, D, E, and K, and are a key component for the infant's brain development. Now, depending on the stage of breast milk production that a new mom and a mom who has been feeding her infant for several months, the differences in that breast milk does vary greatly in terms of its fat content. It can depend on the number of pregnancies the mom has had. It can depend on the time of day when the mom may be feeding. It can depend on the mom's dietary intake. And what you will learn is that breast milk often is a reflection of mom's diet. Preterm milk has great fats, and preterm infants born prior to the normal full-term 40 weeks, do need large amounts of fats, and thus breast milk from the preterm mom is vitally important, if at all possible. You will learn that colostrum is that early or first milk that comes in. It has a little bit of a different makeup than breast milk thereafter, but that colostrum has a large amount of lipids and cholesterol, but greater fat content is found in mature milk. So we do have less fat content in the colostrum or in that first early milk, but it does have great lipids and cholesterol in that. In terms of protein content, which we know is very essential for muscles and organs to grow and develop and is key to the growth and development of the infant in general, the primary protein in breast milk is whey. This breast milk, one of the things you're going to learn and that we're going to talk about as we talk about infant feeding and frequency of feeding, is that breast milk, because the protein content is so easy to break it down, is very quickly digested by the infant, Within approximately 90 minutes of a feed, infants will digest that formula, and therefore they need to be fed much more frequently throughout the day. It is not uncommon to have a newborn breastfed baby to feed every 2 hours around the clock, then eventually stretch out to every 3 and then every 4 thereafter. But it can be exhausting and tiring to the new mom and something we need to take into consideration. But breast milk is very quickly digested by the body. The micronutrients that are found are vitamins and minerals. Fat-soluble vitamins are present in breast milk, but vitamin D is the only vitamin that is really needed in terms of supplementation for the newborn. Breast milk, maternal milk, does not have as much vitamin D as the child may require. And so in the first several months of life, we will likely supplement with vitamin D for the breastfed baby. With regards to formula-fed babies, over the years, formula has improved greatly in its ability to mimic breast milk. It is not something that we are able to exactly mimic, but certainly companies have gotten better and better at getting it to come closer and closer to breast milk content. In terms of fat content, the fats in formula have been altered to mimic those found in breast milk. And they add vegetable oils, believe it or not, to that formula in order to make it mimic breast milk more closely. Breast milk still contains, though, about 167 fatty acids that are not present in formula, which is pretty incredible. It's just not something that we are able to duplicate. Protein content, casein is the primary protein found in formula. Remember, we had whey as the protein that was found in breast milk. Casein is much less easily digested. And so what will often happen is that that will be reflected in the frequency at which a formula-fed baby may feed. So in the early days, we may feed every 2 to 3 hours, but fairly quickly thereon, we may stretch to every 3 hours much more quickly than we will see in the breastfed baby. In terms of micronutrients, fat-soluble vitamins are present in formula, and the supplementation is rarely, if ever, needed. The final thing I want to touch on in this quick voiceover PowerPoint is doing a nutrition assessment on infants, children, and adolescents. You discussed nutrition assessment in your nutrition class. All I want to touch on are some of the more specific differences in what we may do that is different for pediatric nutrition assessments. So the first thing we will do is do an analysis of growth and development measures. So we will measure weights and lengths, head circumference until the age of 2 years, and we will convert to body mass index. From there, we will use gender and age specific growth charts to plot where our child is or how our child is growing and developing. We like to see children grow on a curve, an ascending curve, and not nice steady growth. One thing to keep in mind for cultural sensitivity is that growth charts were originally developed in the United States, and so we may notice some differences if we do have other cultures that we are assessing. They may not plot quite the same on our charts, and it's something for us to be aware of. Overall, if we are watching infants, children, and adolescents grow, we want to see that nice, steady increase on the curve and not variations, sudden drops, or sudden rises. When we analyze those plots, remember, we want to see that a patient is between the 5th and 95th percentile. When we're getting around the 10th percentile, if we notice changes, we may begin to assess a little more closely to see what may be going on with the child. Or if we are hitting the 85th to 90th percentile, we are going to begin to investigate and assess a little bit more as we are approaching what we would deem overweight. Under the 5th percentile is considered undernutrition. Over the 95th percentile is considered overweight. But remember, we do have to look at the steady growth, the size of the family and the size of the parents, and overall looking at length and weight in comparison to one another, and thus through the BMIs to determine, is that child that's on the 5th percentile still growing and simply a part of a very small family. These are two growth charts. They're kind of hard to see, but you did see them in the lab. And the one on the left, the blue chart, is for the boy, and the pink, obviously, for the girls. The second thing we will do is a physical assessment and laboratory findings to track nutrition assessments. Certainly, we're going to be doing assessments to look at nutrition status, skin, hair, nails, and hydration status is a good reflection of that, as well as our BMIs. We may draw lab values, most particularly hematocrit and hemoglobin, to determine nutrition status. We may look at glucose levels, fasting insulin glucose levels, lipid profiles, cholesterol levels, and renal and liver function tests. All can give us a picture of a nutrition status. We will also look at dietary intake, but in the differences, we may look at mother's intake during pregnancy so that we can kind of look at where the child may be. Maybe we have a small for gestational age baby because mom's intake was poor, and we can go ahead and try to work with the family to get the child on target. 24-hour recalls are always helpful. Anything more than a 24-hour recall can be very difficult to remember. So screenings, questionnaires, and diaries are very helpful in pulling information together. We also always need to pay attention to nutrition risks, food insecurities, history of eating disorders, parents and caregivers who have eating disorders or who are obese. Those types of things are things that are going to ask or require us to assess a little bit more in depth. These two tables are from your book. They really just talk about some general dietary screenings for children and infants. And remember, if it's infants, we are going to ask about breastfeeding or formula feeding, how they ate, when they began their solid foods, and how they tolerated those. In older children, we are going to look at who's preparing the food, does the child select foods, what are their favorite foods, and does the child get any physical activity.